Thanks, everyone. Thank you. Good morning, everyone. Welcome to the Rural Caucus. Thank you for joining us bright and early. And today, as advertised, we're going to be talking about rural health care. So, Mr. Malik, would you like to kick us off? And if you could introduce yourself and explain what Meritus is.
Well, thank you very much. Good morning, everyone. Hi, I'm Malik Joshi, President and CEO of Meritus Health. And Meritus is a not-for-profit regional health system in Western Maryland, Washington County, Hagerstown, Maryland. And we are a 327-bed level 3 trauma medical center, as well as a behavioral health facility and the new Meritus School of Osteopathic Medicine.
Wonderful. Because I think not everybody knows what osteopathic medicine is. Can you explain that briefly?
Certainly. So as I would say, osteopathic and allopathic medicine, DO or MD, are both equivalent physicians. They prescribe, they go to the schools, they go to residencies, they pass the same exams. And so they all have the same credentials. Their difference is osteopathic physicians have additional hours of training in osteopathic manipulative medicine, where they are much more diagnostic and hands-on. Today, 1 out of 3 physicians in training are in DO schools versus MD schools. And osteopathic physicians tend to go more into primary care specialties,
which we desperately need.
Correct.
Do you want to say a little bit about the particular challenges and opportunities you're dealing with in Western Maryland, and what's unique about the fact that you are in a more rural area?
Certainly, thank you. And again, I know my colleagues will jump in as well, of course. I would say there's 4 things I would highlight. Number one, we just talked about is physicians. Physicians throughout the country, we have a shortage. In Maryland, we have a shortage, but it's more profound in rural areas. Just not enough physicians of all specialties. So it's not just primary care, but as we say, you know, people still unfortunately fall and break their hips and knees and everything in rural areas. So that's a big one. The second I would say is mental health. In fact, rural areas tend to have a higher rates of overdose and suicides compared to other settings of care. So rural health is a major issue. The third I would say is Medicaid. Rural areas also tend to have a higher percent of Medicaid, and hits to Medicaid really impact the delivery system because individuals still need care and they still come to see you, whether it's the emergency, regardless of their ability to pay. And we take care of everybody. That's our job, is to take care of our communities as anchors, all of our rural institutions. So that's a third. And the fourth, I would say, is the social determinants of health: transportation, food, loneliness. These are the types of things that are also more exacerbated in rural settings. So when you put all those together, I think just additional challenges. And again, the fact is most of our organizations, I see Steve Leonard on, I mean, we are anchors for our communities. We're the largest private employers. We're the ones people come to for medical care and non-medical care. And so I would identify those 4.
Interesting. Okay. Please jump in. I would much prefer to have this be a discussion rather than a series of presentations. So if anybody wants to respond to Mr. Joshi, that would be great. And I just wanted to ask you, before that, it does strike me that transportation is a particularly difficult one in rural areas. How are you addressing that? How do people get to you?
It's a great question. So we do have a commuter bus line and other ways, but let me be frank, what we did 2 years ago is we went all in on transportation. We have 9 vans, 9 drivers, a dispatch person. We have Ride Central software, and we provide now 17,000 free trips a year for anybody in Washington County that needs to get to a medical appointment. That's our view of how we help support this. We're not by ourselves. Of course, we partner with others and we rely on the county, but we just have to do it ourselves. And it's been a big opportunity. People use our transport for chemotherapy, physical therapy, primary care. It's not just to get to your doctor's office. It's for lots of things that they just are challenged to get there. So, even though we have Hagerstown, we go as far west as Hancock, 30 miles away. People need that. We also now have one dedicated van just for our mental health hospital and their visits.
That's incredible. And it must be quite a cost.
It is, and we've been fortunate to get some grants and other things, but our view is do it and figure out the money later. And that's our job. So
That's amazing. Wow, that's terrific. Anybody else want to address some of what Mr. Joshi was talking about? Good morning.
This is Cheryl Chaffee. I'm the president and CEO of Frederick Health, and I want to underscore the importance of the DO program and the school that Meredith has stood up. That's going to be for our state to have more access to providers. The other thing that we're really proud of in Frederick County is APPs, or advanced practice providers, getting those programs stood up at Hood College for nurse practitioners, and then the new program that we'll be starting for physician assistants up at Mount St. Mary's University. That's another way to really help make sure that we are providing the workforce that's necessary to take care of our communities. There is this tipping point where we are currently in our organization pretty equal with the number of physicians and the number of APPs that we have caring for our patient population. So it's really important that we continue investing in programs that are also turning out the physician assistants, nurse practitioners, and others who are not quite physicians, but are going to be critical to meeting the shortages that we are seeing in the healthcare workforce of providers.
Absolutely. Yeah. I mean, that's true all over the country, not just the state, but I can imagine it's more difficult in rural areas. Are the salaries lower, or is it just harder to attract people wanting to open a practice because there are just fewer potential customers?
So salaries are typically lower for APPs, and reimbursement follows at a lower rate for advanced practice providers. So I see it as one way that people are entering into the provider profession, where you can still advance in your career to become an APP, but not quite the full investment that it takes to become a physician. It's much longer, much more expensive to become a physician. So it's another path to elevate to the next level and provide that direct care for patients as a licensed independent practitioner, but not quite, the expense and the time that it takes to become a physician. So it's a really good option to provide, care for our community and get more people who are willing to go down that path.
Yeah, right. Exactly. Thank you. I see we also have our Assistant Secretary of Health, Elizabeth Kroom, on the call. Do you want to say a few words?
Sure. Good morning. Thanks so much for having us here and bringing this topic up. I'd be delighted to talk about the Rural Health Transformation Program, if that would be helpful. I know you'd like to have a discussion, which I agree it's so much better than slides, but I do have a small presentation. If it would be helpful, I can share just to kind of walk through some of the specifics of this program because it's so detailed.
That would be fantastic. I just wanted people to feel free. Don't feel like you can't ask a question, make a comment, jump in. But yes, that would be great.
Great. All right. So, and please do just let me know as I go if there are any questions. But just to recap what this funding opportunity is, this came out of HR 1 at the federal level, and it was $50 billion over 5 years. And basically, if you think about the funding opportunity, it was kind of two buckets. There was half of it was available to all states based on completing and having a sort of deemed eligible application, and those dollars would be distributed equitably, across all 50 states. And then through the same application, states were competing for the second bucket of dollars. And then based on a pretty complex scoring rubric, states were awarded a variety of dollars over and above that sort of baseline funding. This is a cooperative agreement with the Centers for Medicare and Medicaid Services. So it's a little bit different than how we've operated in the past with our federal partners with traditional grant agreements. We do have a risk of having our future years, project years funding reduced, or even money we've already spent clawed back if we don't meet the performance goals of our plan. So what was available to Maryland was anywhere from $500 million to $1 billion over the course of the 5 years of this program. In terms of what counts as rural, so when we were being evaluated as a state with our application, the federal government used federally identified or sort of federal definition of rural, which is a much smaller group of counties and census tracts in Maryland. But in terms of the counties that we could identify as being eligible for funding through our initiatives, through our Rural Health Transformation Plan, the federal government allowed the states to actually define what we think of as rural. So we used what is in Maryland code, that 18 of our 24 counties are considered to be rural. So anything that you see here on the map that has a color in it, we've counted, and those are then counties where the initiatives that we're proposing to do can actually be placed. We went through a community engagement process. This was a real sprint. It was 6 weeks from the release of the notice of funding opportunity to when the application was due. But we did get in both in-person and hybrid listening sessions across our rural areas. We put out a request for information and ideas, received over 300 of those and sorted through them. We also did roundtable discussions with a variety of different partners. So our award, so for the first year, so this is a 5-year program, but basically we have to be reassessed every year. So we were awarded for project year 1, a little over $168 million. That was 84% of what we proposed. And in terms of when we look across the country, we received more than double the average amount per rural resident. We had to reduce our budget and submit a revised budget because in our application, we were asked by CMS to actually build a budget based on $200 million for the first project year. So we needed to, get a 30-some million out. But in doing so, we did not cut any of our proposed programs or eliminate them. We just had to move some of our dollars around and make some reductions. In terms of our plan, 3 pillars. Think about it as 3 pillars. The first is related to rural workforce. The second is really, and these are just the buzzwords from the application that we needed to match for CMS, but think about number 2 as access to care. And then initiative 3 is around food. And given the fact that this is a different type of agreement with the federal government and the risk of, reductions in funds in future years, we have 2 buckets of funds within each of those 3 initiatives. The first is immediate impact. So things that we know are shovel ready, they have a budget, they're ready to go, they can start once dollars are unrestricted. The second bucket is what we're calling transformation funds. So these are actually competitive grant opportunities in certain categories where we'll be able to accept applications and then review an award based on, the best and brightest ideas coming into us. We thought that was a smart approach to be able to sort of make sure that we're able to show progress and limit our risk of potential reductions in funding in future years. In terms of the types of things that we're funding, you'll see here, this is at a very high level, the different areas, but on the workforce side, things that are ready to go. So area health education centers are a really great set of programs for connecting to workforce and helping with training and retention and all of that. We have a terrific one out on the Eastern Shore. We have one in the western part of the state. We don't have one in Southern Maryland. So what we've proposed to do is actually create one in Southern Maryland and start and get that going, in addition to expanding the programmatic offerings within the Western AHEC and the one that's on the Eastern Shore. They already have a set number of things that they know they want to do to expand, so we can go with that. In terms of The second initiative area, which is really about access, this is a mix of ready to go things and items where we'll do our competitive grant process. But for example, I know a little bit talked about primary care previously. There was an existing grant program that was through our Office of Advanced Primary Care that took applications to actually provide seed funding or startup dollars for primary care practices. There were applications to start primary care practices in rural parts of our state that there was not enough funding to support. So we already know right now we have people who want to go into rural areas and open primary care practices. So we will be funding those. That's an example of an immediate impact type of fund. In addition to think about school-based health centers, we have more interest in starting those than we had dollars for from the Department of Health side. So we can go and get those moving. On the transformation fund side, for the access to care piece, there's a whole fund that's dedicated to behavioral health. And this will be tied to what our Behavioral Health Administration has identified in terms of gaps in the care continuum. They have a really nice roadmap. So this fund will be going to support in rural areas the programs where we know we're missing either in the outpatient setting or other parts of the continuum. We're also spending a lot of dollars on mobile health. We're working through our local health departments. We've asked them to actually create regions. So in the West, sort of the Western three counties working as a region to identify their prime health department where we can fund through a unified funding agreement dollars, and then they work together with community partners to define what does mobile health mean for the community, what's best there, because it could be anything from sort of point of care testing and preventive services all the way up to and through community paramedicine, right, or alternate sites of care and treatment. They define that, and then they fund the work to implement mobile health services within that region. Just a couple of examples. On the food side, so these dollars are not allowed to be used to actually purchase food. So that's certainly a limitation. But we know there's so much evidence around the importance of food and health. And we can support things with our AHEAD model, with other dollars around medically tailored meals, medically tailored groceries, produce boxes, all those great sort of clinical food interventions. But we know that we have gaps in our food system. So what we decided to do with these dollars, since they're really sort of one-time startup dollars for the most part, is that we'd focus on where the gaps are in the food system. We think about where we can go to improve that post-harvest work. So making sure that there isn't a loss of actual product. How do we do cold storage and create cold storage chains? How do we support individuals and organizations that want to go in and do mobile markets or start grocery stores in areas where we have hunger hotspots? And then, of course, nutrition education and things like that. The transformation fund side of this will be to look at, in our rural areas, where do we need more aggregators and food hubs to connect individuals to healthy foods. So you see here, the largest bucket is really this access to care piece, and where we're proposing to spend about $126 million in our first year. And then our workforce side is the second largest bucket, followed by the food piece. And then we do have our, 0.7% of our total award is for the administration side of the grants management, fiscal piece, and the reporting and auditing component. And just a note about our timeline. So this is really interesting how this all works, because it doesn't line up to our state fiscal year, but we have to have all of our budgets for each individual item. So even think about, we have a partnership with the Department of Labor around apprenticeships. So we want to create more apprenticeship programs. That's great. We've outlined, we think it's going to cost X. Here are the components that we think we would be funding. We have to get that individual budget approved by CMS in order to have those dollars unrestricted and for us to start spending. So we're going through this process. We're waiting on CMS to approve our final revised budget. We have to do that for each of these areas. And then once they're approved, we have to get all of those dollars allocated by the end of September of this year for the first project year. But we have until September of 27 to spend the first project year's dollars. Everything needs to be allocated, appropriated, assigned, but we can spend up until, for those approved uses, up until September of 27. And you see here, it just kind of follows on from there that there's a bit of an extension in the actual spending of approved uses beyond the first budget period. So we're continuing with our engagement with communities throughout this process. We put out a call for applications back in January, extended it thanks to all of the snow and ice that's been happening around here. So it was open for a little over a month to create a Rural Health Transformation Committee. We're in the stages of finalizing the roster this week with our first meeting set for February 26th. This group is going to meet virtually at least quarterly. I think it's actually might be a little bit more in our first project year, and can advise and receive updates on implementation of this program. All of these meetings are open to the public with dedicated time for public comment. We'll put all of our notes online and keep people updated. We also asked with the applications if there were individuals who are willing to serve as a part of review committees when we get to our transformation funds and putting out the competitive grant applications. So we have a really great starter list of individuals who, one, are willing to serve on the committee and provide their expertise, but also those who are willing to participate in review committees, which is really important. We do have a webpage within our State Office of Rural Health on our Maryland Department of Health website where we've been putting all of our updates. We also have a dedicated email that is looked at by several people every day and responses are provided, but we're really trying to make sure that we're posting everything online in a timely manner. And we've also taken all of the information that we got from our listening sessions, requests for information, and other folks who've reached out to us, and creating a listserv where we'll be able to proactively communicate in addition to what we're putting on our website.
Wow, that was absolutely phenomenal. Thank you so much for that. I think we're going to see city folk moving to rural areas to get some health care, but Delegate Hutchinson.
Thank you, Delegate Ziegler. My question is for Mr. Jossi. And just first of all, I want to clarify, it's Mr. or is it Doctor? I can't remember.
It's just Malik, but it's Doctor.
Okay, so this may persuade the answer here. So I represent the Eastern Shore on the Health Committee, the newly formed Health Committee, and I often look at scope of practice bills, and I look at those with a really fine-tooth comb. Is this the right thing to do? Is it going to affect patient safety? And you'd mentioned that you're a behavioral health facility as well, and we're going to be looking at a bill this year, and it's a scope bill to allow prescribing rights for clinical psychologists who've gone through a master's level program in psychopharmacology to be given prescribing rights. And I look at the Eastern Shore and I say we have approximately 20 psychiatrists on the shore and about 166 clinical psychologists. Any opinion on that in terms of helping us in terms of our behavioral health issues that we have? If you think that's not the right approach, is there another approach that we should be looking at? Just trying to navigate this bill that's going to be coming before us.
Well, thank you, Delegate Hutchinson. It's nice to see you. And I think Cheryl, brought up really nicely about advanced practice providers as well. Scope of practice, I don't know specifically about that, but scope of practice in general, we do need to elevate so that APPs and licensed therapists and psychologists can elevate their practice and prescribe and do the right things. I think with the shortages we have and with the right supervision with those providers, it's a good thing. That's how you expand access in many ways, because sometimes that is a barrier for someone if they need to do that. Again, right supervision and all that, I think elevating it, everybody would say that's how you expand a workforce too. It's not people sometimes, it's what they do appropriately.
Excellent. Thank you so much. Just to the caucus, this might be a bill we want to be monitoring as well. Thank you.
Delegate Morgan.
Thank you, Madam Chair. This is for the Secretary, please. I have two questions, and they sort of go hand in hand. The first one is the ability to attain goals in order to receive the funding. Are the goals realistic or too far off, or how would you characterize that?
It's a great question. So what we tried to do in setting the goals is aim for being optimistic yet also realistic. So for example, in our workforce pillar, we actually put in much more, I'd call them process measures. So the number of new apprenticeships actually created and done in time, instead of saying that we're going to reduce, emergency department wait times through new apprenticeships. I mean, we really tried to make sure that we could attain something within the project year. So wherever possible, we were doing the small steps of process measures. So numbers and counts of things. But even in the food side, that one was a little bit easier for us because we know for the impact funds, for example, with cold storage, thanks to the work that the Food Resiliency Council did as a part of the Maryland Department of Emergency Management, we know where they need the cold storage done and what needs to be bought. So that is actually a great outcome to say we can meet that goal of X number of cold storage things in these parts of the state, put in place, operational, functional, and moving. So I think we were able to really get specific and be realistic while also, to the extent that it was needed, being a little bit aspirational as well. So
Okay.
I feel confident right now, and particularly with the how we've sort of split up the funding, because a lot of it is also just getting the dollars out the door, that we'll be able to meet our goals. But we also, this is an ongoing negotiation, right, with CMS. So if things change that, we're unaware of right now in terms of if they decide that they want to go in a different direction with allowable outcome measures, then we're going to have to reevaluate and figure out how to make that work going forward.
Okay, and the second question I have is, you say where you get like $186 million of the initial grant along the way. So the conject the route, I don't know one way or the other. So they said that the big bad beautiful bill was very detrimental to rural areas. Yet simultaneously, as I've listened to you, it didn't seem that the big bad beautiful bill hurt Maryland that much. Is that a good statement, a bad statement, or how did Maryland Health bear with the rural counties in the bill at the end?
So I think, so the way I've been thinking about this, if it's helpful, is that this rural health transformation program is a really unique opportunity to focus specifically on rural health issues, and not to say that we don't deal with rural health issues. I mean, the State Department of Health works with all Marylanders, right, to improve the health of all Marylanders. But the fact that we get to really hone in on and focus on our rural areas is of great value. And so we want to make the most of this opportunity. And in some ways, it's, an infusion of new dollars that we didn't have previously. Take, for example, what I mentioned in primary care. We had a program to fund new practices, right? Seeding new practices. The money would only go so far. We now have other dollars to be able to put primary care practices in more areas. And we knew that there were practices that wanted to start up in rural parts of our state that we didn't have the dollars to support.
Thank you, ma'am.
Can I just jump in and say, just specific to Washington County, the number of people that are projected to come off Medicaid because of the bill in the future is equivalent to us at about $4.5 million of revenue. That's more than 50% of our margin. And last year we provided 19.9 million of free care in our community. So it's a big hit. It's a big hit to rural hospitals down the road, because these individuals we still take care of. They still come to our emergency rooms. We still see them regardless of their ability to pay. So it is a huge hit to the revenue. Again, I'll ask my colleagues to jump in on that as well.
Yeah, Malik, if I could, I think one of the responses that's probably prudent to have is we haven't seen the full effect as well. I think there's what we know, and then there's erosion over time. This is a 10-year bill, and there's different things that happen over the course of the next 10 years with the big, beautiful bill. And I think some of the unintended consequences of Medicaid enrollment definitely they're in the short term, obviously with uninsured population and bad debt. But something we're closely monitoring is organizational ability to maintain status such as 340B, which is based upon your Medicaid disproportionate share percentages. When organizations, especially rural hospitals, if they lose their 340B savings program that allows us to acquire drugs at a discounted price specifically to serve under folks at risk, that's an exponential impact even on, for us, that's like $10-12 million, just that 340B. So it's definitely very concerning. And I think we don't know. We know the short term, but as this continues to evolve, I think there should be more caution.
Mr. Leonard, I wanted to also ask you to introduce yourself.
Sure.
And if you want to say a few words, can I first just call on Delegate Weigel, who has been patiently waiting in the waiting room with the question. Delegate Weigel?
Yes, thank you, Madam Co-Chair. Just a question to the Assistant Secretary. Where does all the grant funds go? I'm just curious hearing Dr. Joshi talking about the Medicaid cuts and all. Does any of that money go to hospitals for some of their innovative programs that they were talking about, or is it restricted from going to them?
It is not restricted to going to hospitals. So I would certainly expect that our hospitals and health systems would be applying for grants within these transformation funds. And even with some of these immediate impact funds that we're doing in workforce and in access, and maybe not in food and immediate impact, but at least in the other two areas, there are opportunities for hospitals as well through those various partnerships. So these dollars cannot supplant or replace funding that already exists or funding for services that can be covered through typical means like reimbursement through insurance coverage. So there are a lot of restrictions on these dollars, but hospitals for sure should be able to, and I know we've had several conversations thanks to our MHA partners. In addition to, I know Malik and I have had many conversations about the Rural Health Transformation Program. They should be able to see themselves in several different components of the Rural Health Transformation Plan.
It's a great introduction to Mr. Leonard. If you want to say a few words and introduce yourself.
Sure. Just going to share the screen just to kind of give some context. If you're not familiar with Tidal Health, we're a 3-hospital system over on the Eastern Shore servicing Lower Shore as well as parts of Delaware and of Virginia. In our service area over here, we have about 600,000 people spread throughout that region, which is the equivalent of the city of Baltimore. Yet we have thousands of square miles. So I definitely appreciate the conversation on transportation, Malik's efforts. It's important for, rural hospitals. We can't build one clinic and serve 50,000 people like you do in Baltimore. We have lots of little clinics throughout the region. We are anchored by what we are evolving to as far as an academic-like facility on the Eastern Shore. And that's really where I want to spend a couple of minutes. In my perspective, our largest challenge as a healthcare system is the transition of physicians from independent practice to be employed by healthcare systems. The subsidy required to support physicians, 50% of physicians in the country are now employed by healthcare systems. 25 to 27% are employed by large Wall Street-backed national firms, and less than 25% are independent, and that number is going down consistently each year. We have a line out the door of people wanting to be employed because economically speaking, physicians cannot make it as much as they used to in independent practice due to poor reimbursement. So we actually have 1,000 team members in our physician enterprise, 500 providers, 33 different specialties. If we did not employ them, they would not be on Delmarva to the degree they are. And I'm sure my colleagues feel the same way. And the pressure is significant with the subsidies. For us, it's all about that supply and demand. So as Malik opens up a medical school, I could tell you we're happy about that. And we're trying to change the rural supply of physicians. So Tidal Health became independently accredited to train physicians in residencies and fellowships back in 2020. We did this right after the first wave of COVID, probably the craziest thing we've ever done. And I can thank the board because we've invested tens of millions of dollars into an unfunded startup cost associated with residencies and fellowships. Why did we do it? 90 to 95% of the training in this country is in urban environments. If you train urban, you will stay urban. That's the data. But if you train rural, if you grew up rural, went to a medical school like Malik's opening, and you had your clerkships in rural environments, and then you go to a rural residency or fellowship, more than half of the physicians will stay rural. And that's what it's going to take to really move the needle on supply and demand for physician training. So Tidal Health has 19 approved programs at this point in time. We're on our way to about 25 approved programs. We can only do this because there's significant volume and pathology and medical staff competency here. We do get to do some fun things like set up continuity clinics and ER hotspots in Salisbury that was supported by the state and Secretary Jake Day. So there are some neat things we can do on the pop health side by combining medical education with population health, especially in at-risk areas. We did have to invest in all kinds of simulation and training centers, conference centers, you name it. We do a lot of research, but this is probably the most fun chart that we have out there. We're heading to about 220 residents and fellows at Tidal Health. And once all of these programs are what I call filled and starting to matriculate, we'll graduate 74 physicians every year across all of these residencies and fellowships who are predisposed to go to rural environments. We hired 60% of our first class. One went to Wisconsin. Great. It was in the middle of nowhere in Wisconsin. It was rural. 3 went on to great fellowships. We hired 80% of the last IM class. So again, that's how, in our minds, we have to establish funding mechanisms for these things. We had to, I'll just say, negotiate with the HSCRC to do this. In any other state, it would have been a free pass. There were additional steps we had to go through with the HSCRC. And I will tell you, some of those steps have limited my colleagues' abilities to do this financially. And it is within the state's capabilities to address this in the long term. The federal government has indicated a willingness through AHEAD to actually have more residencies and fellowship funding for rural areas. So I think it's definitely something we're going to want to continue to promote. We're almost maxed out. There's a couple, we had a 5-year agreement to start whatever we could, and we started 25. And that actually puts us in about the top 10% of all GME programs in the country. We're probably one of the largest rural programs in the country. And I don't think anyone has started as many as we have in 5 years the way we have. But again, I have to thank our organization, because the unfunded startup costs tens of millions of dollars. Now, we get some money in rates to support the residencies, but to get them going, it's been extremely expensive. But happy to say that, I think we'll be the 5th largest in the state, but, obviously Hopkins and Maryland, they tend to outweigh most others. So that's a little bit about workforce. Again, to me, I appreciate the conversations about Medicaid in terms of at-risk populations. But for us, I can tell you that physician subsidy, because, by the way, Maryland reimbursement for physicians is, I think, the 3rd lowest in the country. So if you're not getting reimbursement for physicians, you're taking it out of hospital margins. And that's a formula that's just become more and more challenging. So I know there's lots of discussions about how do we improve physician reimbursement? How is that recognized by the state? Because if it's not us, quite frankly, it's Wall Street. And if it's not us, I think we'd rather have us than Wall Street. And everyone's waiting in line to get on one or the other. So I'll stop there. And I'm sure Malik, we're looking forward to having, your medical students here, train them, and hopefully send them back to rural areas within the state.
Very interesting. Thank you so much, Mr. Nicholas.
Hi, thank you so much. Good morning, everyone. I thought it might make sense for me to chime in. Can everyone hear me okay? Make sure I'm connected. All right, thank you. So I'm Andrew Nicholas. I serve as the Senior Vice President for Government Affairs and Policy and General Counsel at the Maryland Hospital Association. And thank you so much for having us here today. Really appreciate it. Wanted to kind of put some of the things that you've heard into even a broader context as to what's going on for hospitals in the state. I do have a few slides I could share briefly that may help just walk through some of this. But I think you've heard, let me see if they come up here. There we go. Is that working?
Yes.
Excellent. So you've heard some of the challenges that we're facing in rural communities. They, from healthcare access to economic development challenges with infrastructure and health outcomes. There are disparate health outcomes in rural communities. I'll provide a little more on that in just a moment. I think these are challenges that we're seeing everywhere, but just a little more acutely in our rural communities. And nationally, you do see some higher health disparities in rural communities from heart disease, cancer, chronic lower respiratory disease, stroke, and in unintentional injuries. So it's not a unique issue to Maryland, as was mentioned. But what's going on in Maryland that is unique is how is within the model, context of transitioning to the AHEAD model. And so for those of you on the health committee, this may be somewhat of a repeat for what you heard in a briefing, but for those who aren't familiar, the AHEAD model is the latest iteration of Maryland's unique reimbursement model for hospitals. And this is a big transition. It is a big change. It is different from any version of the model that we've had to date, and the model goes back 50 years. And the fundamental change is that Maryland, it is that the foundation of the model has been that it is an all-payer model. And by that, we mean all payers. Maryland had the ability to set the reimbursement rates for hospitals across all payers, Medicare, Medicaid, commercial payers, everyone, and they were set the same. So hospitals receive the same reimbursement regardless of which payer. In other states, your public payers, your Medicare and your Medicaid, reimburse far below the cost of care, and private hospitals negotiate reimbursement rates with private insurers at a higher rate to make up for that difference. In Maryland, everyone was set the same. This was a great experiment to try to expand access to care, and it was successful in many ways at ensuring everyone had access to care. You could go, we don't have public hospitals in Maryland that other states have that only really serve Medicare, Medicaid patients. Our hospitals serve all patients. Everybody has access in their community or to an academic medical center. Yes, sir.
Sorry to interrupt, but I want to be very careful when you say everyone's revenue is set the same. It's not true. We all regulated revenue. It is not the same. Maryland rural hospitals get less GBR revenue per EC Med than other hospitals in the city of Baltimore. So let's just be careful. It's not all the same. We are disadvantaged in this state.
Absolutely. So not all hospitals are set the same. Reimbursement rates per hospital, per service line within them are set the same. But absolutely, of course, my board member hospital president is absolutely correct. It does vary hospital by hospital for what your reimbursement rates are. But that element of the model is gone, that all payer nature of the model. And that's a significant deal because in this iteration, CMS has taken away the ability for Maryland to set Medicare rates. And that they are now reducing Medicare reimbursement rates in Maryland significantly. And so what we are facing is a total of $870 million in reduced payments in reimbursement for Maryland hospitals over the life of this model. All right, so that is a significant reduction of reimbursement. And so right now, under the policies under consideration, only about half of that is being made up in the payment policies going forward. And so there's a lot of uncertainty out there among our members for how we're going to navigate this new future and ensure that we're able to continue to provide the access to care that we currently do, given this reduced funding. And so just to add a little more detail on this implementation, hospitals are continue to ask to do more. They've increased the amount of savings. This is to Medicare, basically reduced the amount of money Medicare spends in Maryland. Was originally $230 million under this model. Now it's $460 million, despite Maryland hospitals are now receiving $870 million less in payments from Medicare and Medicaid. Hospitals now have to navigate two separate regulatory schemes because private commercial rates and Medicaid rates will be set by the HSCRC, and that's the Maryland State Rate Setting Commission, while Medicare rates will be set by CMS and the federal government. So we'll have two different regulatory bodies that we'll need to answer to and be responsive to. They will also set different targets for our quality metrics. So that is all new for hospitals. So all of that going on while also continuing to have to invest in population health initiatives, which has been part of the model, but now with fewer resources coming in, but those investments expectations continue. So it is a challenging time. It does, there's a lot of concern out there how we're going to navigate this. And there are several issues, kind of headwinds that hospitals are facing as we're navigating this new system. You've heard about the workforce challenges, denials, demographic rates. I'll touch on just a few of these in more detail. So I think folks are aware, Maryland, like the country, our population is aging, with the baby boomer population now in retirement age. It's estimated that by 2030, almost 20% of the population will be 65 plus. The number of Americans with 3 or more chronic diseases will be over 83 million. And this is particularly felt in rural communities, as you see over here, where almost every metric they have a higher rate of incidence of all of these various chronic healthcare conditions, including folks with 3 or more conditions. So again, this is a problems that we're seeing everywhere, but again, more acutely in our rural communities. Increasing physician costs. I think Mr. Leonard made a great point about the increased physician costs. To be clear, so what Maryland hospitals are having to do, because we are the 3rd lowest reimbursement rate for physicians in the country, is pay physicians extra money. We have to subsidize physicians to get them to serve in our hospitals, or we wouldn't be able to provide care. And an issue we're running into is that right now, those funds are not being factored into our rates. They are just lost. So I want to flag that, because for those of you on the health committees in particular, there is a bill being introduced that would require the HSCRC, or clarify, I think honestly in my mind, that the HSCRC needs to consider those losses when they're setting hospital rates. So that there is something there that may lead to at least a little progress in those as far as hospital rates go. It will not impact the fact that Maryland reimbursement rate for physicians remains very low. Payer denials have been increasing dramatically, particularly over the last 7 years. I mean, so when we're facing over $400 million in reduced reimbursement, if we could get reimbursed for the care that we are currently providing, that would go a long way. It would certainly help. But that is not happening. As you can see here, 1 in 8 inpatient claims has a denial in FY24, 1 in 7 emergency department claims, which is extraordinarily frustrating, because we are under federal law required to treat everyone who comes in, and we do, and yet we still see a large number of denials related to emergency department care. And then 1 in 10 outpatient claims that are seeing a denial. So it is across the board. Many thanks. Again, this is another one that you will see a bill on this for those of you in the health committees that is trying to address particularly those emergency department claims and reverse some of these practices. But we're also engaging in the statewide adverse decisions work group to try to improve this more holistically. And then, as was mentioned, the expected rise in uncompensated care from HR1, our preliminary analysis estimates that the uncompensated care rates could increase by as much as 30% this year. And so without coverage, the impact that this has is without coverage, folks forego care, they delay care, and when they can't access those preventative care, they can't access care further upstream, they end up in the hospital, and they end up in the hospital often sicker than they would have been otherwise. And so not only is it uncompensated, it's now more complex and more costly to treat. And so that's just another, I mentioned that as just another factor and element that hospitals are facing and having to confront within the context of facing significantly reduced reimbursement rates in the years ahead. So there's a lot of challenges. I think, it's something that's going to take all stakeholders, including our policymakers, paying very close attention and working together to ensure hospitals have the resources they need to continue to provide the access to care that our communities expect and need. So I'll stop there and happy to answer any questions.
Thank you very much. That certainly is a range of challenges. So we are almost at time. Is there anybody else who is dying to chime in here? And if not, I have a question I'd like to ask, and that is about SNAP payments, SNAP and SNAP Ed, I guess directed to Madam Secretary. your thoughts on that situation.
So you mentioned SNAP ED. So, you know, through the Rural Health Transformation Program, we're not able to, I'll just say we've many restrictions on the dollars in terms of how we can use the dollars, but we did actually put in, and CMS did not have an issue with it, a significant, I guess it's in immediate impact funds, dollars to go to local health departments in rural areas to work with their community partners on nutrition education. So it is not SNAP ED, but it is significant community-based nutrition education through health departments and their community partners. So at least on that side, we know that we can continue to do that really important education work on the health promotion side related to nutrition and food. I'm wondering, you know, something that we would be delighted to do as the Department of Health, along with our colleagues over in DHS, is if you would like to do something with this caucus as it relates to HR1 and specific impacts in rural areas, we would be delighted to come and do a briefing or just talk through the numbers as we know it, the estimates, some of these other policy pieces that you heard sort of the top line components of from our hospital and health system colleagues in the MHA. We'd be delighted to put a little more detail on it from the state side as well.
That sounds terrific. Please let's stay in touch with that about that. And before we leave, I do want to say for anybody who has a specific great idea for how the Maryland General Assembly could help alleviate some of these problems, please share that with us. We're actively looking for bills that we can support as a rural caucus. And it is our hope to be a part of the solution. So I know we all have other meetings to get to. Thanks so much to everyone who shared this information. It was a great discussion, and have a great day. We will see you next week.